Assalamu alaikum. Let's talk about the non-surgical retreatment. The retreatment can be an option of treatment when the failure of the indoor treatment happened. We'll discuss what are the reasons that caused this failure. It can be poor cleaned canal, or shaped, poor obturation, missed canals, ledges, perforations, broken files. These are all reasons that may cause the failure. As for the treatment, the dentist has many options. One of them is the retreatment, the non-surgical one, and taking this decision must be based on evidence that the prognosis of our retreatment will be better than any other option. Our options can vary from doing nothing and only observing the case, or extracting the tooth, doing the retreatment, the non-surgical or the surgical one. So how do we do the differentiation? First of all, we must know that doing a retreatment of a tooth that is poorly obtured is easier than doing it with a tooth that has been obtured properly, because the bacteria has become more persistent to the treatment when the canal was previously obtured well. As for the lack of healing of some endo-treated tooth, we must get suspicious about that we are dealing with a cyst, not a peri-apical lesion. So in this case, for example, apparently there was a good non-surgical retreatment, and this lesion was persistent. So after we extracted it surgically, it was a cyst, and we see that after 4 years, a scar has been formed, because the lesion was actually big. A scar is not bone formation; it's more about a connective tissue formation, but the healing has occurred after we extracted this tooth. So there are two types of cyst, of periapical cyst: the pocket cyst and the true cyst. For a true cyst, they have contained cavity or lumen with a continuous epithelial lining. As for the pocket one, it is open to the root canal of the affected tooth. So the true cysts do not heal following the non-surgical treatment. As for the pocket, they may heal, but it's not definitive. This is actually something that sours the heart. This patient has been treated for years with unneeded endo treatment because it was misdiagnosed, and the reason for the pain was non-dental pain. So we really emphasize on the importance of true and correct diagnosis. There is always so many different ways of treating, but there is only one correct diagnosis. We must take it in our mind. We have spoken previously about how to do the diagnosis, the procedure, and the differential diagnosis. If you are interested, you can watch the episode of that we discussed previously. Here the author is emphasizing about the importance of the CBCT. But interesting that they are saying that after the doctor has taken, for example, a certain treatment plan before doing the CBCT, then he did a CBCT, the additional information that the CBCT has given the dentist is actually made the 60% of the treatment plan of the cases, 60% of the cases has changed the treatment plan. And I found that this actually a really high percentage of changing the plan due to the information that the CBCT has given us. We usually use a small field of view to decrease the radiation, and not every case needs a CBCT. Here we see that for the apical radiograph, the missed canal was not detected, but doing the CBCT, we can detect that there was a missed canal. Actually, also for the vertical fracture, the CBCT was more showed it more obvious, clearly. Yani. So doing the treatment, as we said in the beginning, for example, let's see this case. This patient had this endo treatment for 7 years. When we did this radiograph, we saw that there was a lesion around the tooth. But the patient was asymptomatic, so he refused to do the retreatment. This tooth stayed from this prior to after this radiograph another 6 years until it became symptomatic and the retreatment was done, which means that this treatment has stayed for 13 years without any problems. And although we saw that there was a radiolucency around the apex, there was no need to any treatment unless there are no symptoms. Every case has its own condition and story, so wisdom is important. As for doing, for example, here, this tooth was misdiagnosed. It needed only a simple treatment, endo treatment. The dentist extracted the tooth and did a bridge. The adjacent abutments had caries under recurrent caries, and they were treated. So the patient at the end has lost the vitality of 2 teeth and lose the tooth, the actual one that was extracted for no need. For example, these cases, if we did a treatment for it, we would open the tooth to the periodontal space, and there is danger of having a pocket, a chronic periodontitis. So extraction was better for this case. Also this one, we had vertical fracture that caused a split tooth, and maintaining this root as hemisection was had a poor prognosis. So extraction was indicated here or advised here. Also this case, we can see that the post and the tooth is really weak. The same thing is for here. So having a good vision of a case is important. Here, for example, we can see that the vertical fracture was suspected. So we did the exploratory surgery to confirm it. Then it was extracted. Now, uh, if we did our diagnosis, we studied all the possible uh, treatment plan, and we went to a conclusion that non-surgical retreatment is indicated. So let's discuss the steps that we are going to go into. The first thing is getting the coronal access cavity preparation. Most of the tooth, usually an endo-treated tooth, are covered with the crowns. So we have two options. Do we remove the crown, or do we open the access cavity from the crown itself? If the crown has underneath is not good, which means that it has caries underneath, it's not occlusally not very well, so it's easy to do the decision. We remove it and we do the access cavity without the crown. As for example, here we have the case, the crown is good and the patient has no time, or for example, he has traveling, and he does not have the time to redo, or financially he has some problems in redoing the crown. So we doing opening the tooth from the crown is indicated here. Although we get a limited visibility and limited access to the canal orifices, also if you have to remove any posts, it will be harder. But some cases demand this. When we decide to remove the crown, there are so many options that help us in doing so. We have this pliers, it's called pliers, that has rubber on its tip with a powder that can that protects the crown from getting scratched. Also, we have this that is called the rodent bridge removal, where the tip is also inserted on the margin of the crown, and the body of the extractor here is put. The adjacent tooth is used as a fulcrum, so with squeezing the handle together, we cause the crown to be elevated of the tooth. This is its mechanism, and we know this. We use it in our country frequently. This is also another shape for this type of extracting machine, or we use first we cover the crown with an adhesive, and then we melt this putty and insert it in this clamp. Then we wait until it gets hardened. After that, we use this to give vibration that leads to the removal of the crown. This method is about using hot water to make this putty soft. Then we let the patient bite until it gets firm. Then we take it out and the crown is removed. Now let's talk about the procedure of removing a post, which the rule says it's not important what is removed, it is important what is left behind. For example, removing here, when we removed the post, we can see that the tooth has weakened and restorability of the root is questionable. First, we remove the cement around the post with high-speed hand piece using cylindrical tapered carbide or diamond burrs. Then we use the slow speed ultrasonic tips. We go on the circumference of it, going around until until we break the cement bond, and the post decreases its retention, and we facilitate its removal. It is important that our ultrasonic strikes do not exceed 10 to 15 seconds, because to prevent any heat damage to the periodontal ligament. Chloroform can be used to dissolve the cement around the post before we do the activation of the ultrasonic instrument. This post has been removed by an ultrasonic tip. We insert it in the space between the cement and the post and do round motion around its circumference until it gets loose, and we grab it out. There are some specific kits for this procedure, and their use is different from country to another. For example, this type, it's called the Egler post removal, that grabs the post after we remove the cement coronally. This kind of technique is popular in Australia and New Zealand. On the contrary, this method is the least used in the United States. So the methods vary according to the country. Here they're saying that we can use a methylene dye to locate the post precisely and prevent any dentinal unnecessary removal. This is another way to remove a post by drilling inside it using what is called the gyro tip technique. The heat that is generated from it loosens the matrix that binds the fiber optics by each other, and the flute's design makes the procedure safe. The instrument is covered with a material that reduces the heat generation and makes the procedure safer. Regardless of any method we use, after we remove the post, we may have some complications. One of them is the perforation. It can happen during our post removal, especially if the post is removed by simply attempting to drill in it with high-speed burrs. If perforation occurs, the clinician should repair it immediately, as the prognosis will worsen as the time between the perforation and repair lengthens. Once the perforation occurs, the clinician must reconsider the prognosis and determine whether the tooth should be salvaged, terminating the procedure and different treatment options. For example, here are saying, or another complication is the bone burning. This case, the clinician has used the ultrasonic tip for 5 continuous minutes, even though there was a water spray, but the patient has suffered from the slowing bone, and he lost the tooth after 1 month of the procedure due to the heat generation from the ultrasonic tip. Now, after removing the post, whether it is metallic or fiber, we have to gain the access to the apical part by removing the 𝐏𝐻𝐿. We can remove it by heat or solvents and mechanical instrumentation, and we can combine them combine these methods together. But if the 𝐏𝐻𝐿 has a plastic carrier, we should not use heat to remove the coronal 𝐏𝐻𝐿. We use heat to soften the 𝐏𝐻𝐿. Then it must be, the heat should be applied in a short burst to allow instrument to penetrate the 𝐏𝐻𝐿 mass. We use 10 to or 15K files to remove the quota if it is poorly obtured. But if it's not possible, we can use a solvent like the chloroform or the Resilon to remove the remaining material. What is the difference between the chloroform and the Resilon is that chloroform is faster in doing the procedure. We can get the effect of it in the same time we apply it. As for the Resilon, it needs more time. These solvents have a degree of toxicity and should be used carefully to prevent any accidents, but they are regarded safe if it was used wisely. We usually apply these solvents using an irrigation syringe. Also, they are mentioning here the C+5 that are effective removing the 𝐏𝐻𝐿 because of their stiffness. What makes them stiff, they are made of stainless steel, is that their taper varies along the shaft, giving them the rigidity and strength to cut through well-condensed 𝐏𝐻𝐿 efficiently. As for measuring the working length after the removal, the apex locator does not give us the accurate reading due to any residual solvents or quota present. So we do the radiographic image, or we can do further cleaning of the canal and take the apex reading. Here are the C files that can be used for classification and the removal of the 𝐏𝐻𝐿. The author is giving us a trick of removing the 𝐏𝐻𝐿 that extends the apical area by using a new headstone file, inserting it to the further beyond the apex in 0.5 to 1 millimeter. Then we do a clockwise rotation and remove it slowly without doing any movement inside the canal or rotation. We should not use solvents to soften this area because it will make things harder. And this method works in many cases. Here he is mentioning some names of retreatment files to remove the quota. What makes them different is the tip, because the tip of these files are cutting tips. They're hard. If you used the rotary 𝐏𝐻𝐿 removal, we use afterward the subsequent hand instruments to remove any residual obturating materials completely from the canal. So if you want to use rotary removing of the quota, we first apply chloroform to soften the material. Then we insert these files. What happens is that the quota, the instruments, the rotary files generate heat and melts the quota, easing to remove it. Also, it's a chipping inside it. So we are mechanically chopping up the 𝐏𝐻𝐿 and thermoplasticizing the root filling mass via frictional heat to to aid in the removal. And this is the cutting edge of the retreatment instruments, indoor instruments. This is the famous XP shaper instrument to remove the 𝐏𝐻𝐿 of the canal. Its multiple curvatures along the length increases the amount of contact between the instrument and the walls of the pulp canals with irregular contours. Here there is a material that we need to talk about. They stopped using it from 2014. It's called the Resilon. It was suggested that this material is an obturation material by its own. The reason for choosing it is that it has its resin bonding effect, which means that we get the monoblock effect as the root and the obturation material and the root becomes one, and this was said that it strengthened the root and increased its resistance to fracture. Unfortunately, this material is not stable and breaks down within the root over time. When retreated cases that were obtured with this material, they found a discolored, soft, easily removed breakdown materials in the canal. We stopped using the Resilon. Nevertheless, we should be aware that we may face this material, obturation material, in the tooth now when we do the retreatment. Now let's talk about removing the plastic carrier. Plastic carrier, whether it is the tooth is fully the root is fully obtured with it, or it was used to obture the apical part and a post was inserted above. Either of these cases, how to remove it? We can see that clinically it looks like a dark spot in the center, and around it is the 𝐏𝐻𝐿. We first remove the 𝐏𝐻𝐿 around these carriers, and then we flood the space with the chloroform, and we start inserting the manual headstone file beside the carrier, and we proceed deep slowly by doing a clockwise motion until we feel that there is some movement. Then we pull the headstone file upward. The carrier may be removed fully, or we can grasp it by a hemostat. And we should replenish the solvent frequently as we penetrate, decreasing the size of the files from 25 until we reach the A file. So for removing a carrier, two things: we should not use the thermal. We should not use heat for the plastic part, but we can use heat to remove the 𝐏𝐻𝐿 around. Second, we do not use rotary files to remove these carriers, so we do it manually and using a solvent, a chloroform. Here, if the plastic Thermafil carrier is in the apical area, we can use the system B heat blugger by inserting it to the inside the canal. Then we generate the heat and insert the blugger inside the carrier. Then after the attachments happens, we we turn off the heat, and we wait for some time until it's gets firm around the blugger. Then we insert it. Then we extract it out. Now let's discuss the methods of removing the broken file in the separated instrument in the canal. Here are so many different ways and systems. Also, there is a specific kits that we will see proceeding. We will see later. These we have the refine burrs. We have a special kit. We have this is called the extractor system. Also, a glue that can be used to attach the separated instruments and so on. When the separation happens, a radiograph should be taken immediately. This will confirm the separation and gives the clinician information about the location, the size of the file segment, and the anatomy of the tooth. This is important for the legal consideration. The patient should be aware about the accident, and it must be detailed documented. After removing the file, it must be preserved as an evidence if for any proceeding complaining from the patient. The first rule in removing an separated instrument is the visibility. We must see it. We have a straight line access to it. Also, if it is it can be reached coronally, we can grab it by using the Stygulet's pliers or hemostat. The Stygulet, it's like a hemostat, but it has a 90-degree curve or angle. Then the ultrasonic tip is placed on the staging platform between the exposed end of the file and the canal wall, and is vibrated around the obstruction in a counterclockwise direction that applies an unscrewing force to the file as it being vibrated. It is advised to cover the orifices of the adjacent open canals with cotton or paper points to prevent the removed file fragment from falling into them, causing further case complications. Here, the ultrasonic tip that we were using to remove the separated instrument has broken, and if you were not putting these cotton pellets, this fragment would have get into these formants. This is one of the methods, is using the refine burr and inserting with it the headstrong file that the tube is slipped over the obstruction, and the headstrong file is gently screwed into the space between the tube and the obstruction. Pulling the tube and headstrong file together can withdraw the obstruction. Also, we can use the BTR pen to grab the file after we do some loosening of the separated instrument using the ultrasonic tip. We can use the adhesive with spreaders by trying to remove the separated instrument. It is a method. I think it's especially if the instrument is beyond the apical portion of the tooth. The author here is giving us some advices, but that eases the procedure. But there is no definite rule in removing the separated instrument or a post or a Thermafil carrier. It at the end of the day, the dentist can develop his own or her own method and protocol, and we can use a lot, combine many of the techniques that has been discussed in this chapter. So we have each dentist uh, can have his own way of doing it. There's no definite rule about it. For example, here the Terushi file kit has all designed to get all the techniques mentioned in the text. So we can see here the ultrasonic tips, the burrs, the Endo Explorer, the BTR pen. Also, the separated file can be removed when we do the activation of the solvent. It can happen that uh, the canal irrigation system can remove the instrument file. Now let's discuss ledges. How to get along these edges. Ledges are actually a torture to the dentist. This case, for example, because the previous dentist did not made the obturation to the full working length, these necrotic um, pulp remained made an inflammation response that made a calcification in this area. The 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 patient was symptomatic, so we needed to open this area. It took 3.5 hours over 3 appointments only to open this area and reach the whole working length. After doing the obturation, the patient was asymptomatic. Let's read together the procedure. They're saying that we must do the crown down technique to flare up the canal space coronally. Then we start by pre-curving an 8 or 10 file to approximately 45 degrees with the shaft of the instrument. The directional stop is oriented to the bend, and the file is carefully negotiated to the level of the ledge. Since ledges form mainly on the outside of the curvatures, the directional stop is turned in the direction of the suspected apical curvature, away from the ledge, which means that if the ledge is directed to this way, the curve, the bend must be in the opposite direction, so that we can fix the direction. And if we did the opposite, we will worsen the ledge and increase it until it becomes a perforation. Once we get the catch of the file, we must do some preparation before getting it out of the canal. Then we do a radiograph to ensure that we are in the right direction. Once the ledge has been bypassed, we do a push-pull forces to keep the file tip apical to the ledge. and to clean and enlarge the apical canal space. So we do an anti-curvature filling will enable the clinician to blend the ledge into the canal preparation. This is for dealing with ledges manually. But what about using the rotary instrumentation? We must use it with first we bend it like the manual 1 to 2 millimeters from the end, and we set the motion to reciprocal motion, and the speed must not exceed 150 rotation. Then we go slowly until we bypass the ledge. In some cases, like this one, the clinician managed to bypass the mesial root and do full obturation, but the ledge was not accessed in this in the distal root, so he did the obturation, and the tooth was under the following up. We can see that the healing occurred and the patient was asymptomatic. We should inform the patient of this complication, and that we that this thing decreases the prognosis, and we must do regular re-evaluation of the. After removing the obstacles, which was the posts or the remaining 𝐏𝐻𝐿 or the separated instruments, or dealing with the ledges, we must do now which is what is called the searching for the missed canals. Here we see that missed canals were detected and obtured. Now, the last complication that we may handle, which is the perforation. Perforation happens to mistakes in the instrumentation, so it is considered an iatrogenic incidence, which means it is the fault of the dentist. As for perforation, it has 3 types according to the location of it. The first one is the floor, the chamber floor of a multi-rooted tooth, and the coronal 1/3. We usually use the MTA as a material to close the perforation, or we can use we have the endosequence or the biodentin as materials of choice. As for a comparison between them, I believe it was here. While other bioceramics like biodentin and endosequence handle more easily than MTA and also set well in both moist and dry environments, the set material are not as hard as MTA. So it is, until now, it is more preferred. How do we apply it? By an amalgam carrier or a small syringe, and it is usually condensed with bloggers or micro spatulas. Now let's see how we deal with perforations. Here we have a furcation perforation in a multi-rooted tooth. The first step is to control the bleeding and make an isolation of the tooth using a Teflon. Then we close these orifices of the canals. After that we We apply the MTA after mixing it to the space, and we insert a cotton that is wet cotton over it and close the tooth and wait for another appointment until the MTA um, has fully hardened. When we open it, we may be faced by that this material has seeped into the orifices, even if we put a cotton, for example, pellets or files to prevent um, any closure of these orifices, but some leakage may happen. We remove it and we do uh, the obturation as it must be done. Now let's see how we deal with the strip perforation. I believe here they did an apical surgery. Yes, here for this case, the midroot perforation was not able. They are saying that there was an MTA overextension, and there was an inability to negotiate the canals. So these complications were fixed using doing an apical surgery, and we can see the healing that has happened. Now let's read how to manage the strip perforation in this case. This patient was in extreme pain following initial endodontic instrumentation by her dentist. Mid-root level perforation found on axis. The original canal was found and protected with an endodontic file. MTA was vibrated using ultrasonic energy applied to the file, to the tip of the file, and it flowed into the defect. Then the file is moved in a push-pull manner to dislodge it from the MTA prior to the closure. Note that the defect was intentionally enlarged to allow for more predictable application of the MTA. On the second appointment, the file is withdrawn easily since it was detached from the MTA repair material. Now the endodontic therapy is concluded as normal. The patient has been asymptomatic since the end of the first appointment, 27-month follow-up showing complete healing. This is the final case that we will discuss in this chapter. Let's read it together. This lower second molar became symptomatic many years after non-surgical treatment. Non-surgical retreatment had a guarded prognosis due to the large multi-root cast custom post on the core. Surgery was also precluded by the poor access and proximity of the inferior alveolar canal. So what we did is we extracted the tooth and we did an ultrasonic root end preparation is made in the extracted tooth. A white MTA retrograde filling was placed. Note the C-shaped here, canal shape, immediate post-implantation radiograph, this one. Then, after 7-month re-evaluation showing the apical healing and the patient was asymptomatic. In conclusion, there is no replacement that functions as well as natural teeth. This is a fact. Armed with the information in the preceding section, appropriate armamentarium, which means the armamentarium, and the desire to do what is the best for the patient, the clinician will provide the foundation for long-term restorative success. Reasons of endodontic treatment failure: canals that are poorly cleaned, shaped, and obtured, apical transport, ledge, perforation, and missed canals. Right diagnosis and determine prognosis before the treatment initiation is important. Several recent studies have shown that if clinicians are given all the collected diagnostic data, including periapical radiograph for a patient, and they make a treatment plan, if they are then given a CBCT volume of the same patient, they change the treatment plan in up to 62% of the cases. The steps of the non-surgical endodontic treatment. First step is the coronal access cavity preparation. By deciding to remove or retain the crown, PMF crown, we use diamond burrs for ceramics and carbide burrs for the metal. If decided to remove the crown, there are many ways to do so. The second step is to remove any obstacle, whether it is a fiber post or metal post. We first remove coronal cement with high-speed diamond burrs, and then we insert ultrasonic tip around the post, going around the circumference in 10 to 15 seconds intervals to prevent any periodontal ligament burning. The third step is to remove apical cotaberca with heat of system B tip or by using solvents like chloroform or Resilon. Then softened cota is removed manually or with rotary files. The Thermafil plastic carriers are removed via solvents and headstone files. Rotary files and heat must not be used. The headstone files are useful in removing cota that exceeds the apical foramen. The fourth step is look for the missed canals. Fifth step, managing separated instruments by having direct visualization of it. Then it can be removed by fine burrs or headstone files or ultrasonic tips or glue or BTR pen or specific kits with filling the canal with EDTA, and each clinician can develop their own best way of instrument removal. Sixth step is managing the ledge by curving the tip 1 to 2 mm following the rubber stopper direction. Then we insert it in the canal to fill the catch and do a push and pull movements. Then we take radiograph to evaluate the progress or rotary files in reciprocal motion and low speed, 150 cycles per second or minute, with curving the tip can be used. With curving the tip, yes. Seventh step is management of perforations. It depends on the location. The chamber floor or furcation perforation is managed by closing adjacent canal orifices with cotton pellets or files, then condensing MTA in space. Then a wet cotton is applied and the tooth is closed. In second appointment, the MTA hardens and the obturation of the canals is performed. Strip perforation that happens in the middle root can be managed by inserting a file that reaches the apical area and prevent material blockage. The MTA is delivered to place by ultrasonic vibrations applied to the tip of the file. The file is moved up and down to prevent the sticking with MTA and is left in canal until MTA hardens. In second visit, the file is removed and the canal is obtured. Normally, saline is used instead of hypochlorite perforation in apical area and demands full canal obturation with MTA.